We'll be ready to start muscles that actually move the upper extremity. So on Tuesday, we're going to be looking at muscles that go from the scapula over the shoulder joint and attach onto the humerus to move the humerus, and muscles that cross the elbow joint, cross the wrist joint, and cross the finger joint. So we'll do muscles of upper extremity. Probably maybe not get to the hand on Tuesday. We'll kind of have that kind of split over 2 days. So may I erase the board now?
Winter?
Okay with that?
Yeah.
I like how I speak for everyone here.
I can tell you right now, Brian. So, yeah, it's the final.
It's the Tuesday for this unit. It's the Tuesday of brain.
All right, so on the diagram, we're looking at the nerves that innervate the muscles of the chest and breathing, and looking at the diaphragm. When we talked about the cervical plexus yesterday, and so this is a diagram of the cervical plexus with the ansa cervicalis is a loop right here, but that does muscles in the neck, and so it's the phrenic nerve, this one right here, that's C3, 4, and 5, C3, C4, and C5. It kind of looks like the greater splanchnic, picking up components of those roots and descending down through the opening created by the clavicle and down into the chest all the way to the diaphragm. All right, so it has quite a ways to travel to get to the muscle that it innervates. Intercostal muscles are innervated by T2. T1 is actually part of the nerves going into the upper extremity. So we start with T2 through T12, and those do not form a plexus. They pass. Here would be the ventral ramus right here. These would be the dorsal rami doing the deep muscles of the back that we just talked about. And so at each spinal nerve level, these are going to pass in and pass through the intercostal muscles that we're going to talk about in just a moment. They do not form a plexus. So each intercostal nerve is the ventral ramus at that particular level. Okay. So muscles of the anterior chest wall that move the ribs. We're going to look at the, give it here. We're going to look at the pectoralis minor. Actually, that's in my previous. Sorry,
Totally. Brown all over this? It's just dirt built up. Yeah. I like on the chairs too. You see like the dark brown lines? Dirt.
So this diagram right here is showing the pectoralis minor, not quite as clearly because it has the fascia over it, but I'll diagram it on the board for you. And this is one that we talked about. Actually, I was jumping ahead of myself. But we'll do it first since we've got it up on the board rather than make you flip your pages around even more. So turn to page 88, and we'll do the anterior chest and then do the posterior chest. So we have the sternum and the clavicle. And the clavicle is attached to the acromion, if you will, of the scapula. And then we have the coracoid process of the scapula. It's the anterior component. Ribs. A few more than the three I have drawn here. So the pectoralis minor, normal origin is ribs 3, 4, and 5. Insertion is onto the coracoid process of the scapula. And so it's going to attach in this fashion. It's deep to the pectoralis major. This is where we do have a distinct difference between a minor and a major muscle. All right, zygomatic is minor and major, same origin, same insertion, same function. When we get to the superficial back, rhomboideus minor and major, same origin, same function, same purpose. Pectoralis minor and major are two completely different muscles, different origins, different function, different insertion, and of course different function. So pectoralis minor is deep to pectoralis major rather than above it, or superior to it. Origin is the ribs, insertion is the coracoid process. So if you put your hand just below your clavicle, all right, and then try to push your shoulder forward, you can actually feel the pectoralis minor contracting under your hand. Feel it tightening up under your fingers? And so the movement of the scapula that we're going to be talking about with these muscles of the superficial back and muscles of the chest, this movement of pushing the scapula forward is called protraction. So pectoralis minor is going to do protraction of the scapula. It's going to push it up against the ribs. All right? So this is where it's located. You would take your palm, put it on the ribs, and then bring your fingers to attach to the coracoid process. And it's pulling the scapula forward like that. Pulling it forward against the ribs. However, if we switch the origin and insertion, and we make the origin the scapula, and use the muscles of the back that attach to the scapula to keep it from moving, now these muscles will pull on the ribs, and they will be accessory muscles of respiration. So you're at an altitude of 8,000 feet, and you're struggling to breathe, and you need more than just the normal intercostals. These will help to lift the ribs up even more. So that's why it's considered to be an accessory muscle, and we have to switch origin and insertion. We have to change the immovable muscle to the bone to the scapula, and the movable bones to the ribs. All right, the normal muscles of respiration are the intercostals and the diaphragm, and I want to come back to those and just stay with muscles that attach to the scapula. So if you'll turn your pages back, I apologize for starting on the wrong thing here, but turn your pages back to the trapezius. I can't see enough of my title here to figure out which ones I'm looking at. So now we'll come back to this posterior view, and I will put in the vertebra. Again, I'm not counting these. And we're going to be looking at primarily two sets, protraction and retraction. So protraction is pushing the scapula up against the ribs. Retraction is pulling them back. And the other function, pair of functions, is elevation and depression. We're not talking about mood here. We're talking about the position of the scapula.
Can you say that one more time? Protraction. Sorry.
Retraction. Protraction is pushing the scapula against the ribs. Retraction is pulling it away. And then elevation and depression. I'm going to clip it back here.
Thank you.
Uh-huh. Then we have the scapula. And the trapezius is located both above and below the scapula. It can be both synergistic and antagonistic to itself. The origin are the spinous processes of the vertebra, right along the line here. Next week I'll be bringing our cadavers in. So, word of warning, you might want to bring in some peppermints to suck on, or some mentholated Vicks if you were bothered a lot by the sheep brains we dissected. Okay, if not, then it's fine. but otherwise, and we'll have them in for like the last hour or so of each lab. And so you don't want to be wearing wool. If you have a sweater on, have something you can take off and wear something that's cotton. It's a little easier to wash. The wool tends to hold on to the smell. Okay. Notice the fibers here. Origin is the cervical vertebra, thoracic vertebra, and these fibers are going to descend and insert onto the scapula and onto the clavicle. They form a wrapping around the U shape of these two voting processes. So the spine of the scapula is here, and the clavicle is here. Trapezius comes in front and behind to form a U in its attachment. So it's going to do this for the upper fibers. And the lower fibers are going to do this. And so the two muscles together create the name of the muscle, the shape, the trapezius. The two sets of upper fibers do elevation, so they're going to lift the shoulders up. The two sets of lower fibers do do depression, pull them down. You can see that pattern right here. Okay, when they work together, they do retraction. My favorite way of illustrating this is the Legally Blonde movie. Bend and drop, bend and snap. Okay? That's retraction. So hopefully I haven't ruined the movie for you.
You remember that part, right?
You also already know the nerve of innervation for this muscle. Same as sternocleidomastoid. Accessory, small accessory that pierces through the sternocleidomastoid and gets into the deep surface of trapezius. Thank you. All right, now another muscle that also elevates the levator scapulae, but does so at a more unbalanced position, is levator scapulae. So it comes off of the cervical vertebra, but it only attaches to the corner, the superior angle of the scapula. So it will elevate the scapula, but it's more likely to do it like this and drop that outer portion downward. And so this is called lateral rotation or external rotation, and it allows the shoulder to drop more. So this is trapezius. And levator scapulae. You can see levator scapulae on the head models, but it's such a small portion of it that I generally don't use that to illustrate. And you can see it a little bit better on this model right here. Here would be splenius capitis. All right, and then this is levator scapulae. You can actually coming to
Behind your ear?
yeah, they're both behind your ear, but levator scapulae is coming down to the scapula, whereas splenius capitis is coming up here. So they kind of, that's splenius capitis, and you can see this one's actually going to the scapula. All right, so that's why it helps if you pay attention to the name. So when you're looking at the lecture content of this and functions, take a moment to think about that. Even if this is the one area of this unit where even if you don't know the answer right off the bat, you do somewhere. You just take a moment and think about it, process, okay, ask yourself those Socratic type questions. What does the name mean? Where would I find it? What is it attached to? You can often figure, you know what it does, you can figure out its attachments. If you know its attachments, you can figure out what it does. Okay, levator scapulae, you don't have to worry about innervation. And now deep to the trapezius, we see another set of minor major muscles, the rhomboids. And again, you don't need to differentiate between rhomboideus minor and rhomboideus major because same origin, same insertion, same function. These are covered up by the trapezius normally. So rhomboideus minor is superior, and rhomboideus major, which is rhomboideus, or rhomboids are all you have to recognize for them. And their function is retraction. So they're going to, you can actually feel this rather than when we pull both shoulders back, that snap part, you're using both the trapezius. But all you have to do for the rhomboids is just consciously tighten up the area under what you can think of as under your scapula or at the base. Just tighten that up. And try to pull your scapula, your two edges together, and you're using your rhomboids.
So in the wrong, you said retraction, but over here it says protract.
Change that to retraction.
Okay.
Sorry, did I say? I'm wrong. No. It is protraction. I'm sorry, I misspoke. Thank you, Gretchen. So it's pushing the scapula against the ribs. It is protraction. I was saying it wrong. I was thinking of when the nerve doesn't work, they retract. So this is the rhomboids right here. So here's the minor, here's the major. So they do protract and keep the scapula pushed against the ribs. When the nerve to them is damaged, we have what's called winging of the scapula. The scapula comes away from the ribs like this.
Ooh.
And then you would actually see the edge of the scapula pushing out the skin. Okay, Jeff had that happen to him. He damaged actually the nerve to the next muscle we're going to talk about, serratus anterior. And so there was just, it grew back.
Can you fix that?
Yeah, so it was just a temporary loss of function for several weeks or 3 months. But the edge of that. So when it comes away from the scapula, that's what winging of the scapula is. Okay, when that protraction isn't working and the scapula is allowed to retract or come away from.
So how does that
vertebra.
affect you if your scapula is like out like that?
It affects how you can, the range of motion of your upper extremity. All right, that brings us to serratus anterior, so named because of the serrated appearance of its origin, and because of the dark appearance of this muscle. It's a little bit easier to see on this model. So this muscle is attached to each ribs. It's not found between the ribs. Those are the intercostals we're going to end up talking about today. Origin is on the ribs, quite a number of them, even up high. And all of these come together and attach to the deep surface, the most anterior surface of the scapula. That portion of the serratus anterior is actually really thick, about 1 inch to 1.5 inches thick, whereas these are rather thin. And in fact, when I taught the cadaver class at Sac State, I would always warn them to take a look at this part of the muscle at the cadaver because everybody's used to models seeing this part. And then I would tag that thicker belly on the cadaver, and probably 20% of the class would end up missing it. But one of the good things about a cadaver is you can lift up and separate muscles from each other. On a model, you can't do that. You're stuck with what you're seeing. And so I always told them, whether it's an artery or a nerve or a muscle, during the quizzes or the exams, take advantage of that and follow it from its entire length. So I didn't consider it to be a tricky question because I warned them. I would do that. And I also want you, I can't do the thicker part of the belly, but that's what you're going to feel under here. And so there's much more mass and strength to that muscle than just the few slips that you see here. So its normal function, again, is protraction, keeping the muscle, the scapula pushed up against the ribs. Remember, the scapula has no articulation with any part of the axial skeleton except the clavicle at the acromion process. And so it's these muscles it's dependent upon to keep it in place and the upper extremity in place. So serratus anterior, if we draw it from its posterior view, is going to have muscle fibers coming from the deep surface. I'm going to draw that with dotted line. Going out to attach to the ribs. This would be the serratus anterior. And if we have our ribs shown here, then you can see serratus anterior coming in. But it would be coming off with a very thick belly. Now we have other muscles on the back, but they are muscles which cross the shoulder joint, like the latissimus dorsi. And all these muscles from the scapula cross the shoulder joint and insert onto the humerus. So they are muscles that are considered to be moving the upper extremity, moving the arm. And we'll talk about them on Tuesday. So what I want to finish up here are talking about the intercostals and the diaphragm. Yes?
The serratus anterior, is that deep then to the rhomboid? Or is it,
It's,
like I understand the scapula is attached.
okay, so it's actually going the opposite direction as the rhomboid. So rhomboid is going to be filling in here and attached to the medial border of the scapula on the deep surface, going in this direction. So starting where the palm of my hand is, going in that direction is serratus anterior. And rhomboids are going to be over here. Okay? All right, so now let's look at muscles of respiration.
Did you want it?
So here, before we move into that, is a view of the serratus anterior, and it's sending slips up to not just the lower ribs that we can see here, but even the upper ribs. It also is considered to be a muscle of accessory respiration because it's attached to the ribs. So if we change origin to ribs, change origin to the scapula and make the insertion to ribs, then these lower slips of the serratus anterior can help to lift up the ribs and help you breathe in. So before we move on and talk about the muscles of the ribs, breathing is done by a difference in pressure. Air flows in and out of the body due to a pressure difference, just like blood flows through the body due to a pressure difference. So when you open your mouth, and you don't contract any muscles, you just open your mouth, there's no air movement. It's not moving into or out of your lungs. To get it to move in, you have to make the pressure of air in your lungs lower than atmospheric pressure. So you're not sucking air in so much as the atmospheric pressure is pushing it into your lungs. And you only need to make a difference of about 3 or 4 millimeters of pressure between the two for atmospheric pressure to move air into the lungs. And so when I breathe in, I'm doing two things. I'm lowering my diaphragm and I'm elevating my ribs. So the first muscles we talk about are the major muscles of inspiration that elevate the ribs. The ribs are at a slight downward angle, as you can see here on the skeleton. So if you think of it like a pail handle is a common illustration. When we lift the handle of a pail from where it's hanging down, we actually move it out as we're moving it up. So when the ribs are lifted up, they move out more than they were, and that increases the anterior-posterior diameter of the thoracic cavity. Anytime we increase volume, but keep the number of gas particles and the temperature the same, gas laws say we lower pressure, all right? So the intercostals, external intercostals lift the ribs up slightly. Their orientation is from the superior rib is the origin, and the inferior rib is the insertion, and they go lateral to medial. You would put your hands in your pockets, they'd form a V. So that pattern is external intercostals. We put in the external intercostals from the other side. You can see what I mean as far as a V is concerned. So they insert onto the inferior rib, and when they contract, they lift them up. The external intercostals between the ribs come all the way to the sternum. The internal intercostals, however, start about 1 inch to 1.5 inches lateral to the sternum. That's why we can, sorry, the other one. I've had too long a day, folks. I said it correctly, but for the wrong muscle. Let me draw the internal intercostals in, and then we'll talk about. Everything I said function-wise is fine, but not where we can see them. So the internal intercostals are oriented as a V, but they do not come all the way to the sternum. Hence, we can see the deeper muscles. So the external intercostals form the V, but they start out a bit lateral. The deeper muscles are the internal intercostals, and they form an upside down V. And so because they're not covered by the external intercostals right along the sternum, we can see the deeper internal intercostals. So on this model of the breastplate, that's what we call this piece of the model, you can see the serratus anterior. Most of what you're seeing here between the ribs are the internal intercostals. You can see just a little bit of external intercostal here. So I'm going to put my fingers where the external intercostals would be, but you can see the pattern of the internal. So when we put the opposite side in, the intercostal muscles form the internal intercostals form this pattern. The external intercostals are going to form this pattern. Okay? So again, internal intercostals going this way, external intercostals going that way.
Internal that go to the sternum.
Right. Okay. Internal intercostals are these right here, and they go all the way to the sternum. External intercostals stop about 1.5 inches to 2 inches lateral. So the ones that you're actually seeing here are internal intercostals. Internal intercostals are going to function by pulling the ribs back down.